at the table, but this table, let me speak again. And air conditioning works, which is key. I just went back to my apartment and the air conditioning is not. Oh, thank you. Thank you so much. Thank you. Sure, yeah. Thank you very much. Yes. And then Michelle said we'll also be taping, and so we can also get it out of our offices that
Well, greetings. Why don't we get started? As we've already warned our three witnesses today, people do come in and out of these. It's just the nature of when we do them on fly-in day. People arrive when they arrive, they leave sometimes to go prepare for votes. So I want to thank the three of you for being here. I met with a group of mayors this morning, and about a dozen towns, and we spent about half our time talking about the opioid crisis affecting every one of these towns. One of them is probably the most senior citizen-centric town in my district, and yet they've had 47 overdoses in their town. Pretty startling. Saturday, I was at a recovery program that was filled with, in fact, John Brogan was there as well, and that was filled with people in recovery, struggling to get into recovery, families working through the process, and a lot of people that are there trying to help them. And last week, on Monday night, Tuesday night, I was at the Center on Addiction in New York City. It's a crisis that doesn't allow a week or a day or an hour or a minute to go by without arresting our attention, because we have to figure out what to do about this. Yesterday, 174 people died from overdose. The day before that, it was much the same. The day before that, much the same. And today, we are marching towards the same. 174 people. The guy at the Center on Addiction really startled me last week because he kept asking and then shouting the question, if 174 people dropped out of the sky in an airplane crash today, we would mourn. If it happened again tomorrow, we would ground every aircraft in the country until we figured it out. If there were a Parkland shooting, as there was, sadly, and 174 children died, if it happened again the next day or week or month, we would be beside ourselves with solutions. And we're losing 174 people every single day. So obviously we all have a part to play, whether it's those in recovery and their families and local communities and those serving them. We have a role here in Congress as well, largely around funding and policy making. And so we try to focus on that in a we don't try, we do focus on that in a bipartisan manner with 105 members, roughly equally divided between Republicans and Democrats. And this is about trying to end the misery and the cost in human lives and in other ways that this epidemic is causing. We have three witnesses here today that are here to help us understand the treatment side and what works and how we can help people that have been caught in this web. Christopher Jones, I welcome you back from SAMHSA, which is the Substance Abuse and Mental Health Services Administration. You bring a unique perspective. We thank you for coming back today to share with us on this subject. John Brogan is one of our leaders in New Jersey on this. He's the Chief Recovery Specialist in the prosecutor's Blue Heart program. Been involved in recovery from a lot of different angles for 10 years, and you bring your own perspective. And so I welcome you. I'm not forgetting you, sir, but you have a fan right next to me, and I know she wants to introduce you to Brian Rhodes. But thank you for being here. You can help us to do a better job. I believe next month we will bring a large group of bills to the floor of the House that have, to some degree, come out of these hearings and roundtables of the task force. And so we're happy to have you help us know what works today. So thank you for being here, and I yield to my colleague.
Great, thank you very much, Mr. MacArthur, and thank you again for your leadership. It is very rare on Capitol Hill to have 105 members evenly split, but Democrats and Republicans coming together to tackle the heroin crisis, the opioid epidemic, lots of names for it, but we all feel it every single day in our communities. And when you were talking, I was thinking, each of us in our own ways, in our own communities, both in our districts and then here in Washington, are working on this. Sometimes it feels like 24/7. I was with the Office of National Drug Control Policy this morning at a big conference. The Senator Shelley Moore Capito and I spoke. Several hundred people. They literally had come from all over the world, not just all over the country, but all over the world, looking at how to tackle this opioid epidemic, how to intervene with the interdiction efforts, but I also shared with them a lot of the innovative solutions that we are focused on here in New Hampshire. So I'm so excited. I have wanted for months to bring Brian Rhodes down to Washington to share one of the most innovative solutions that we have found in New Hampshire. New Hampshire, like New Jersey and other small states, have been hit very hard by this. Rural communities, small communities. Brian is the chief now of the Nashua Fire and Rescue. Nashua is actually the largest city in my district, about 100,000 people. And but it also is a hub for people seeking help from smaller towns all around. And I am very excited to hear him talk about our Safe Stations intervention initiatives. Together with Manchester, New Hampshire, Safe Stations has helped hundreds of people seek treatment and achieve recovery from opioid addiction. And I want to personally say thank you to Brian for his leadership, and he's actually become the chief, due, I think, in large part to his leadership putting this program together. So as I explained, we will start to be joined by our colleagues. Paul, come on up. Don Norcross from New Jersey, Paul Tunkel from New York, and we'll have others come and go, and we'll give them the opportunity to hear your testimony and ask some questions. At this point, I'll turn it back to my chair and take it from there.
All right. Well, again, I thank you for coming, and to emphasize how bipartisan we are with this. And just had a touch of surgery. My wife and I sent her flowers, and even subconsciously, what color were the flowers I sent you?
Purple flowers. Purple. So impressed. Purple tulips.
But we're so serious about this, actually, that I mentioned we have a legislative agenda that we are trying to move through this Congress. We don't do that unless we have bipartisan agreement here. And every bill we move has to have a bipartisan set of sponsors of the actual bill. Because this is so big that we just can't do it on party lines. We have to do it together. So, Chris Jones, I think we'll start with you, and then in no particular order, Joan will go to you, and the Chief will go to you. And please share with us, and then we'll turn to questions.
Sure. Thank you very much. Thank you for having me here today to talk about SAMHSA's response to the opioid crisis. As you've already stated, families and communities continue to be impacted by the opioid crisis. And really, the emergence of illicit fentanyl and fentanyl analogs has only fueled this in the last couple of years. As the department's lead agency for behavioral health, SAMHSA has been at the forefront of the HHS response to the opioid crisis. Under the HHS 5-point strategy, our work really focuses on prevention, treatment, and recovery support services and overdose prevention, working in concert with our other HHS agencies. We focus on funding to build state and local capacity, education, training, and technical assistance, and data collection, analysis, and evaluation to track emerging trends, identify what works, and support the integration of evidence into practice. I want to highlight a few things that have either been released or actions that we've taken at SAMHSA over the last few months to strengthen our response to the opioid crisis. So in the area of funding, in late April of 2018, we distributed the second year of the state targeted response to the opioid crisis grants. It's $485 million that was originally created under the 21st Century Cures Act. This is pivotal funding for states and territories to reduce opioid overdose deaths and provide the full complement of prevention, treatment, and recovery support services. In March, we also awarded $1 million in supplemental STR grants to New Hampshire, Massachusetts, and West Virginia to expand and enhance STR efforts in the states that have been hardest hit by the epidemic. We also provide funding for treatment and recovery for specific high-risk vulnerable populations. That includes individuals involved in the criminal justice system, as well as pregnant and postpartum women. Last year, SAMHSA awarded funding over 3 years for new state pilot programs for pregnant and postpartum women from an outpatient-based perspective. That was a pilot program that was created under CARA in 2016. We also funded over 5 years new grants to support residential treatment services for pregnant and postpartum women. We also have drug court and offender reentry programs, and thanks to the additional resources provided by Congress in the omnibus, those programs will be strengthened this year. We think that's a particularly important touch point for engaging people in treatment. We've also been a leader in the area of naloxone. So under CARA, a first responders naloxone program was created, and we funded that for the first time last September to provide resources to first responders and treatment providers who work directly with populations at high risk for opioid overdose. We also have had a state-based naloxone program that funds the higher burden states to purchase and train people on the use of naloxone. Moving towards training and workforce and technical assistance, creating a well-trained workforce is really a critical part of our efforts, and integrating evidence-based interventions in practice are key goals for SAMHSA. In January, we created a $12 million state targeted response technical assistance program, which is really targeting the work that's happening under the STR program, and it's essentially operationalized a consortia of experts who will create and work with the states to create state-by-state plans to help and tailor the technical assistance needs for states as they're spending down this large infusion of dollars. We recognize that a single TA center isn't really going to capture the various needs of particular states, and so we wanted to make sure that they were state-centered. We've also been focusing on, again, pregnant and parenting women, and realize that clinicians and patients need guidance in how best to manage individuals who have opioid use disorders who are pregnant, in particular in sort of the postpartum phase, and how to engage and treat infants who are exposed to opioids during pregnancy. We released a clinical guidance for treating pregnant and parenting women in February, which provides essentially clinical vignettes for how to engage this population. In the area of data analysis and evaluation, my job as the director of the Policy Lab, we are standing up the Policy Lab. It was created under 21st Century Peers, and we are charged by Congress to support innovation, evaluate promising practices, and facilitate the adoption of evidence-based policies. And we're prioritizing our work on opioids, given the magnitude of the crisis. In April of this past year, we actually launched an evidence-based practices resource center to provide clinicians, community practitioners, policymakers in the field with the tools and resources they need to adopt evidence-based practices, whether that be in the community setting or in the clinical practice setting. We think that's a really critical need and a consolidated resource where people can go to find what's most relevant for their efforts. And we're also revising our data collection efforts to get more timely and specific data to better assess the impact of SAMHSA's programs. Thanks to funding in the omnibus, we'll be recreating the Drug Abuse Warning Network, which was a surveillance system that existed until 2011. It will capture substance use-related emergency department visits in a timely fashion that can provide sort of direct feedback to communities about what substances are showing up in emergency departments to help guide their efforts at a local level. We're definitely committed to combating the opioid crisis. We look forward to working with you all, and thank you for having me here today.
Good afternoon, Chairman MacArthur, Chairman Kuster, Chairman Kuster. My name is John Brogan. I'm the founder of Lifeline Recovery Support Services and the Chief Recovery Specialist for Ocean and Monmouth County Prosecutor's Office Blue Heart Program. I appreciate the opportunity to be here today to talk about not only my personal story with addiction and recovery, but also my professional experience that brought us here today to discuss successful treatment strategies. Like I said before, I am a person in long-term recovery. I was sobriety date March 19, 2011. Prior to that, my story is not unique. I served in the Marine Corps, and I came home from the Marine Corps and I struggled with this disease. It didn't start at opioids. I drank, and when I came home, my family wanted me to go into the New Jersey State Trooper Academy. I have a wife and 3 kids, and that wasn't in my cards. After serving in the Marine Corps, that was enough of service for me. And so I drank, and the disease of addiction took hold, and I progressed, and it progressed into pills, and then into heroin. At the end, I ended up overdosing 4 times before trying to take my own life. I share that only because of the hope that, there is hope. There's hope for these individuals, and it's been guiding them through the process and the many gaps. I'm very familiar with New Hampshire, and it's a lot like New Jersey. There's many gaps that people like myself at one point could have fallen through. So having said all that, I have 10 years experience with substance use disorder treatment and recovery. That includes crisis management, treatment administration, legal administration, and recovery support services. I served as former Governor Chris Christie's first chief recovery specialist in New Jersey. As an intern at Ocean County College in New Jersey, I developed an efficient system to reach individuals incarcerated for substance use related issues and help to expeditiously place them into the proper level of care and treatment that best fit the individual regardless of financial status. This system would prove to be the foundation for programs developed throughout the state and now the country. By combining traditional drug treatment and peer recovery support services, our programs connect addicted individuals in varying crisis situations with certified peer recovery specialists that work hand in hand with them through the entire recovery process, not just after 30, 60, or 90 days of the process. From initial intervention through clinical treatment to the desired goal of long-term recovery. I've been asked to speak to you today about successful approaches to treatment. Every person struggling with substance use disorder will require a different approach, and it is certainly not a one-size-fits-all. However, I want to share with you a program I developed after partnering with Ocean County, New Jersey Prosecutor Joseph Coronado and Prosecutor Chris Gramiccioni, and now Sheriff Sean Golden in Monmouth County. This program is the first of its kind in the nation, modeled after the Massachusetts program. I forget what town that is, but
Gloucester.
That's Gloucester. That's where we got the idea. The idea was, though, not just for the individuals that had insurance.
Right.
If you're boots on the ground, you know that any good drug addict or alcoholic doesn't have insurance. We take those in crisis and those suffering from substance use disorder and link them to a certified peer recovery specialist with facilitation to treatment and provide the recovery support. We recognize the need for law enforcement to act as partner instead of a barrier to treatment, and recognize where those suffering from addiction would not avoid seeking treatment for fear of incarceration. This revolutionary approach became the Blue Heart Program. This stands for Heroin Addiction, Recovery, and Treatment. I like to always add a side caveat to this. When we first launched this program, there was a treatment center in Florida that we never knew existed, and they filed litigation against the prosecutor in Ocean County because we were stealing his name.
Oh, Jesus.
So it's an interesting, as we get into this space, identify how competitive it actually is. The program allows for individuals suffering from substance use disorder to seek help through the served municipalities. Individuals are clinically assessed and paired with a recovery specialist. We focus our efforts on the at-risk individuals. It's important to know that Blue Heart stemmed from an initial program implemented with the Ocean County Prosecutor, myself, and Governor Chris Christie, called the Opioid Overdose Response Program. The prosecutor's office was able to provide Narcan using forfeiture funds or seize funds from drug dealers, not taxpayers' dollars, that's important to note, to provide Narcan to those who overdosed. We realized that we could also have a program where you would not need to overdose. That was a big thing that we noticed when we launched that program, is why do you almost need to die in order to get into the program and seek help. Between these two programs, we've been able to collect important data in the short time since the program's inception and can demonstrate effective results. Through the program in 2017, this is referring to Blue Heart, 389 individuals walked into a police station. That provoked a lot of questions. Why are people suffering from substance use disorder walking into a police station? 182, still to this day, are in recovery and being tracked. We built a system called the CRM, where everything is being uploaded into one system. So now we can share the data between different organizations. There's all sorts of waivers. I'm not a genius. I didn't come up with this overnight. We learned through trial and error the pitfalls with HIPAA and the non-sharing of information and how that can be critical to someone living or dying. So today, between this Blue Heart and the work program, Ocean County has experienced a remarkable 25% decrease in overdose deaths. Monmouth right behind us with an 8%. Monmouth kind of came along right behind us, in the programs they're now launching this year. Today, I want to walk you through how our approach works and outline the cost savings we've seen to local communities. Upon arrest, an individual is vetted as a candidate for drug treatment. A certified peer recovery specialist is deployed to the police station to perform an intervention and referral into treatment. The two different programs are much different at the moment of crisis. The one that has just overdosed, last time they remembered they were getting high, so they weren't planning on going into any form of recovery. That moment of crisis intervention is much different than the one walking into the police station. Just important to note there. As I mentioned, we work directly with at-risk individuals, and what also we found throughout this process is the amount of individuals coming home from parole, that were coming home from state prisons, ergo the partnership with former Governor Reagan. That was important because he's developed a program throughout New Jersey where he welcomes the guys into his program to re-enter society and kind of scoop them up in the same way that our program Lifeline does. The goal here was to get them into a sober living environment and to also identify the at-risk individuals and cover all the gaps 24/7. That was another big thing that we noticed with the police programs. Everyone in the healthcare industry seems to, for the most part, shut their doors at 4 o'clock. Most of our clients aren't waking up until 7 p.m. So it's a whole change in curriculum. It's a change in culture in order to catch up. We've been successful. The key question is always, where do you get the beds? Where do you get the beds? Through the leadership of Congressman MacArthur, Prosecutor Coronado, former Governor Christie, we established some national relationships and some long-term vetted out programs that we've had relationships for over 5 years now, where we can get scholarships that are long-term programs, no minimum, no less than 180 days for each program. That's just the foundation. There's almost an essential need for that at this point due to the fact of the arrival of fentanyl. We tracked through the prosecutor's office toxicology reports. In 2016, 25% of the dead bodies had fentanyl in it. In 2017, it jumped to 55%. And now in 2018, we're tracking as of last week, 76% of the dead bodies all have fentanyl in it. Again, thanks to Congressman MacArthur, Senator Booker, we were able to become a HIDTA county. Within 6 months of becoming a HIDTA county, I think Prosecutor Coronado cut out one of the largest drug busts in New Jersey's history. They tracked it down to the Dominican Republic, and, overseas, out to California, and then actually took them down in Oklahoma. What we found out a couple weeks later was once they ran the toxicology reports on all of the bags, that they all came back heroin. There was like 90,000 doses of heroin and pure cocaine and guns. The next week, after having a very low number of deaths for Ocean County, as being one of the #1 in the state with deaths for the last several years, we found out that we took the good stuff off the street because we had a rash of 8 deaths that weekend. So we took the good stuff off the streets and they went and got the fentanyl. So the point to all of this is fentanyl has changed the game. They're not shopping, and people are not going to the local drug sets anymore like they used to in Newark and Philly. We use the analogy of Christmas time. How many people actually went to the mall and did shopping, last year? I know we didn't. We ordered a lot of our packages. Kids are doing the same thing. You can get a kilo of fentanyl for $2,000 that has a street value of $1.7 million, whereas a kilo of raw heroin is much more than that. So again, it's about money, it's about price, and the fentanyl now, as we're doing these case studies with Rutgers and Harvard University, you're finding that the effect of fentanyl is having a tremendous on the effect and toll on the bodies of these young individuals. I've been clean and sober for 7 years now. It was different when I was overdosing. We didn't have fentanyl. It's when you think about what it does and how fentanyl shuts you down, it affects the neuroreceptors of the brain, and that's the science. That affects, how you breathe and how your whole central nervous system is affected. So 1 grain of fentanyl can shut down your system in a heartbeat. Thank God for the Haida counties, we've now caught up to where we're giving 4 milligram doses of Narcan. Not everyone has 4 milligram doses of Narcan, nationwide. The individuals suffering from substance use disorder used to overdose on an average of 3 times. I'm sure my counterparts in New Hampshire will share that we're finding an average now is 9 to 11 times. So when they overdose and the receptors are shut down, they're sprayed and jolted back to life with Narcan. Those effects neurologically on these kids, when we're getting them, clean and sober, we're getting them, they're functioning, they're becoming, contributing members to society, but they're having all sorts of other issues down the road. So I share that because we have to be so far ahead of that. And I commend this committee for coming together in a bipartisan way, because we can't be calculating on 2014, 15, and 16 numbers. This thing is growing. We've been sharing through our chairman, Gilmore, with Mr. Norcross out in the Camden area. Heavy hit. We spoke to Chief Thompson last week with Prosecutor Coronado. I mean, they're just decimated. This is a team effort, throughout the state to come together and really put together our best team to see how we can affect this. The good news, and I'll close with this, if I brought in the one more of the Lifeline Recovery Support Service PowerPoint. We can just flip to the whole purpose why we're doing this, the savings to the community. The white page. So a little cliche in there, jails, institutions, and death. In the 12-step program that I follow in my personal life, that's kind of what we tell individuals come in, that's where they end up. There's a little calculation we did in one area of our community. The average cost of an individual that visits the hospital from an overdose or substance use related visit is $5,500. The average person suffering from opioid related substance use disorder visits the emergency room 3 to 5 times per year. I went conservative on that number. I'm sure as my New Hampshire counterparts will share, it's much, much higher than that number. So in 2017, there were 415 individuals that visited 5 to 7 hospitals per county in each quarter. That's 415 individuals suffering from substance use disorder, times 4 quarters in a year, times $5,500 per visit, times 3 times is the average amount of visits, times 5 hospitals. It's $135,950,000 per year in each hospital. That's a pretty significant amount of money. That's just going out the door when they come in. So we had to win the hospitals over. We had to go, because we were seeing the individuals come in and go right back out, or literally put out on the streets right away. When we went in to do the trainings with former Governor Christie, I had to say to them, I understand why you don't want us in the emergency room. We come in angry, we curse at you, we're disrespectful, and then we leave and we don't pay our bills. Why would you want us in there? So we had to come from that bipartisan meeting in the middle understanding to just give us a shot and say, let us divert away from the emergency room. We're not going to send to you unless there's a medical necessity, broken bones, substance use related order issues. Then we'll send to you. But in the meantime, if it's just detox, look, we can get the clinical evaluation and we can move you into a different side. More than half of these individuals also end up in county jail. It's one of our other programs we've got developed. And in New Jersey now, fortunately or unfortunately, we have bail reform. So individuals are going from and we have all of this tracking and data now. They're going from the emergency room, then they're locked up in jail the next day, and now they're detoxed because they've been in a 2-day, 3-day stint, and they're dead on the 3rd day. So thanks to the leadership that we have, we've been able to plug recovery specialists in every single gap just to try to get momentum to plug it and move it in a different direction. The 2016, Ocean County reported 266 confirmed deaths due to opioid-related overdoses. 2017, we reported 159. Savings and efficacy, average cost to treat a person 8 weeks is about $15,000. We do have treatment centers that are not insurance-based, that are true recovery centers in the middle of Pflugerville, Texas, some in New Hampshire, believe it or not, and in Vermont. There's several long-term facilities that we use where you can get treatment for $5,000 to $7,000. But if you do the same math as this whole thing goes down, you're saving $11 million a hospital system. You know, and that matriculates down into the jail system and then all the way into the community. I asked the prosecutor to give me some updated numbers before we walked in as of today to show that we're kind of moving in the right direction in Ocean and Monmouth County. We've had a 35% reduction of Narcan sprays in law enforcement, which equates to the 25% death reduction. So the numbers matriculate down as they go. The 25% death rate has also equal to a new number that we've been working on, which is an 18 to 22%, we haven't captured the exact number, in all our police municipalities, and a decrease in larceny and shoplifting. So the numbers work. So now that we have the plan in place, it's kind of filling in the gaps where we can put the right funding. The regulatory issues, you know, where we are is a work in progress, as we know, and we're working on. So it's the point of this is all of this is, you know, it's all nice to talk about, but one thing is the execution. As you flip to the next page, you'll see Jared B. was one of the first individuals. His mother took those pictures. It was one of the first individuals we saw in the hospital room. That's something we see all the time. And if you flip the page, here's Jared B. 2 years later, he's a recovery specialist for our program. Flip to the other one, here's a more recent. The one on the right was Miss New Jersey, I think 2005, right out of Ocean County. The other one was another girl that was struggling in Monmouth County. If you flip the page, you know, you'll see the results. This works, and it works long term. And I'm just grateful to be here and grateful to be at the table with you guys. Thank you.
Chief?
I brought a lot of stuff. I brought you some data to look at. I mean, I can run you through the state station program and how
Yeah, why don't
things
you
got
explain
there.
how we do it?
It's a little different than, I guess, the New Jersey version. So, but there are some things that I was very interested in. So, I guess for the record, my name is Brian Rhodes. I'm the Chief of Department for Nashua, New Hampshire Fire Rescue. Thank you to the committee and the members for inviting me here today to talk about this horrible problem, but it's the talking like this that'll get us to a better place. So in 2015, New Hampshire was like every other part of the country. We started seeing the uptick. We started seeing a lot of deaths, and everything was pointing toward the opioids. We had 43% of the deaths in Nashua and Manchester, which are the two largest communities in the state of New Hampshire. 139 were due to opioids. 1,139 EMS naloxone administrations, or 42% of the total of the entire state. And there were 850 opioid-related ED visits, which again was 41% of the entire state of New Hampshire. So New Hampshire is kind of a large landmass state, but we're small in population, 1.3 million people. So when you look at the per capita, it's pretty bad. In May of 2016, a gentleman by the name of Chris Hickey, who works for the Manchester Fire Department, he's their EMS officer. He was a member of the Manchester Fire Department, had a family member who was struggling with addiction. And he came in, he brought him to the fire station, and this person said to Chris Hickey, why can't we help him? What can we do? Well, there happened to be a recovery center right next door. And so Mr. Hickey said, let's walk him over. let's water right in, see what happens. Safe station was born. And that's how kind of simple it was at the beginning. Obviously, it's morphed into a much bigger program now. So included in the documents I gave you there, I made extra copies. If people want to see it, you can do whatever you like with it. Anyone. It's a very simple, basic program. So 24/7, 365, you can come to any of these 7 National Fire Rescue facilities. Ring the doorbell, come in, and you're greeted with a warm handshake. You're treated as a person. And I say this because this is what we have heard so many times from people who have come in. We treat them with respect, with dignity. We're talking to them, not at them. And when a person has reached that magic moment, that's what they're looking for. They need that human touch. So the ball starts rolling with us when we walk in. And part of back when we planned this whole, or when we tried to initiate it in Nashua was, so the reality of this is we're about to open up the doors of the 7 facilities in Nashua to the entire state of New Hampshire and beyond. We have a responsibility to the 90,000 plus people who pay their taxes that are looking for us to protect them. So how do we do that? That was done by creating MOUs with a wonderful organization called Harbor Homes, Partnerships for Successful Living. I believe I don't know the correct term, I think it's federally qualified health. So we basically said to them, we'll give you 15 minutes. We'll give you 15 minutes that will be unavailable to get there, to come and to recover that person. Well, we're a year and a half into this, and I'm proud to say that we're hovering under 11 minutes, that my people are unavailable to respond to another emergency. In that 11 minutes, there are 2 people that come. There's a certified social worker or recovery expert. These people are all at the master's level, they're hired, and there's a driver. So there's 2 people in the vehicle with them. So within that 11 minutes, you add another couple more minutes for the person to be evaluated by a paramedic. My people are all EMT certified, so they will do a basic medical evaluation. Again, the forms are in there. It goes, are there any other medical conditions? Are there open sores? Are there lesions? Is the person actively detoxing? If they're cleared by the paramedic, they're on their way. So within 15 minutes of coming into the fire station, the person is talking with a licensed alcohol and drug counselor or a certified social worker. And I think it's hitting them at that point, when that moment of clarity is there, that it's making its mark. Again, we are very fortunate with, so let me just say, that kind of ends the fire department end of it. But once they determine the Harbor Homes, I mean, they've created an 11-bed respite center where they do medical detox at their facility, which has freed up the hospitals. It has taken a lot of load off of the hospitals. So, Kevin, did you print out any more of those?
Yeah, people who can pass this.
These are just some of the statistics you can see that we get together every other week, the stakeholders from the mayor of the city to people from the recovery communities, the police chief, the hospitals, the ambulance service. And we talk about issues, we talk about successes, we talk about failures, we talk about how do we make it better. we have a very good, and it's kind of ironic to hear the story in New Jersey with the police, because in New Hampshire, it was the police didn't want to be involved. For the sole purpose of their job is to enforce the laws of the land. And if someone is doing something or has something illegal, they're going to do their job. They come to the fire station. We do not bring law enforcement in until after the person has left, or unless someone requests law enforcement. We have lock boxes if someone comes in with a weapon, or comes in with illegal narcotics. So far, we've been doing pretty good with that. But I guess, and I don't mean this in a bad way, but if someone is addicted to opioids, they're not going to come in when they have a pocket full of opioids. They're going to come in when it's gone, and when they have that moment of clarity. This has been a wild year and a half, 2 years for me, because I started my 31st year in March with the city. And yes, we used to respond to medical calls, and we responded to overdoses, and it was you go, you take care of them, they go in the ambulance, and you go. As the Congresswoman said, yeah, this has pretty much taken my life over too at work. There is just so much to it. But not only is it helping, are we helping individuals, it is helping my employees. They were starting to show compassion fatigue. They were starting to get very jaded. They were starting to get cynical, and it wasn't good. Knowing that this was happening, we got together with New Hampshire DHHS and the City Health Department, and they created a responder resiliency training for us. So we put all of our people through that. Now, the training is only as good as the person who's going to use it. You can't lead a horse to water. But everything we heard from the members, they were very, very happy, because at least they knew they had an outlet. They knew maybe some of these things they were feeling, what that was actually doing. Unfortunately, I don't see this going away anytime soon. When we put these little areas in our buildings, I said these will be here long after I'm gone, because I just don't think that we're going to be able to totally tackle this thing. It's just gotten so big. We'll get there eventually if we don't give up. But I almost think now we really need to put a lot of emphasis into our children, into the young children. We're doing good. We're doing good with the prescription drug monitoring. I think the medical community is doing better not prescribing opioids. I know our transport provider, American Medical Response Ambulance, has just started a non-opioid painkiller usage in their ambulances. So I think there's a lot of great things happening. We also, we're working with the drug courts. We're working with Harbor Homes. We're working with the hospitals. And I think the biggest thing that I can say about this is the reason this is working is why I think your committee is working. Because this is the greatest collaboration that I've seen in my community in over 30 years. And before this, I think there were a lot of silos out there. And someone said, why do you think this program is working with the fire stations? And I can't take credit for this one. It was, I think, Congresswoman Annie Kuster. He came up with it from AMR. He goes, everyone in the crowd, raise your hand if you know where your recovery center is. Now raise your hand if you know where the fire station is. And it was like so simple that you wouldn't even think about it. But our group, I'm so proud to be a member of the community. I'm so proud to work for the organization I do, for the city I do. We got together, everybody rolled their sleeves up. It was, there were no problems, there were opportunities. And how do we make it better? And I think we are, as the data will we're making a difference. I think part of the problem, we do have an uptick in overdose deaths, but I think that's because of this pure poison that's being pushed out there now. I truly think and believe that we're making a dent in overdoses, but we're killing people because this stuff is so potent.
Well, thank you to all three of you. I think I'll ask all of us if we'll just keep our questions brief enough so everyone has a shot here. And I'll yield to my colleague first to ask a question, and then I will, but maybe we can limit it to one or two questions each of us, and we can get through each of us.
Sure, I'll be quick because I want to make sure our colleagues that joined us get a chance as well. One of the things, when they first started meeting together, I can remember so clearly the hospital coming, and they, one of the first meetings I had with them, and they were just passing out a list of phone numbers, exactly what you were talking about. I mean, literally, I'm sure people left and they were shooting up in the parking lot. Because even if you had the wherewithal to deal with the list of phone numbers, there weren't any beds. There wasn't any place that had room. But the piece I wanted to focus on is that coinciding with our safe stations happened to be that we did the expansion of Medicaid in New Hampshire. We hadn't had that in the past. And I can remember the very first statistics, and I don't know if this is borne out, but of the first 100 people through the door, it was something like 90-something of them were eligible. And what I keep thinking in my mind is, this is such an insidious disease. First of all, the organ you need to solve the disease is the organ that's ill, being your brain. But second of all, you don't have access to treatment. That's what this is all about. We're lucky that Harbor Homes is doing such a great job, but now they have insurance. So my question to you, you said regardless of financial status, you mentioned insurance a couple of times, but how is your model getting over the hurdle of paying for the treatment and also going beyond the 28-day one and done as though that's the solution? It's long-term recovery. So that was my question for you.
Thank you for the question. You have to go for definitions, and that's where we started. What is the disease of addiction? Well, one of them that we stay strong with is it's a mental obsession followed by a physical compulsion, and it's rooted in a broken spirit. You can't fix those three. And what you were describing with the emergency room is, they kind of unwind the brain a little bit with detox, but we haven't worked on the obsession, and certainly haven't worked on the spirit yet.
Right.
So when we dump these kids out there, they're almost in worse shape because they're fully detoxed. You know, and the way the analogs are coming down the pipe with fentanyl, they're changing every day, and they're killing them more instantly, which is why we're seeing the uptick with deaths. The beds, it's relationships, and it's relationships I really can't take credit for. It's a God of my understanding. Where we learn this modality that works, this long-term model, is down in Texas. And it comes from someone that I served in the military with, who also struggled when he came home, and developed, it's called Any Length Retreat. Apparently down in Texas, as we got into this, there's more models like this. They weren't insurance reimbursable because when I first came in, I didn't even understand what Medicaid or insurance was. When I got into it, I started to understand it, and it didn't make sense to me. If Medicaid is where the insurance is that most, 90-something% should have, you have to be 18, you have to be either under 18 and a half or over 64 years old that's our whole population. What these facilities do is they charge a sliding scale, and that's how we modeled the Recovery Support Services program to get it off the ground, which means if you have $1, we'll take it. If you have nothing, we'll take it. Any Length Retreat, their price point is $3,000 to $5,000 with unlimited scholarships because they're in the middle of nowhere and they just have unlimited. Now that's not a sustainable program, but it was enough to get it off the ground and show what works. Show that the long-term model works. And the 6 month is just the foundation. It's the recovery support when they come home that is critical. We just had 2 that came home to Ocean County yesterday after a year and a half. They came home and the public defenders, who's supposed to be defending them, wanted to put them in jail. And we had to take, the prosecutor was the one acting as the defense attorney, going in and saying, Your Honor, these kids had a year and a half. They took $500. That's kind of common with drug addicts. They were working at a pizza place and, waiting tables and decided to leave and go get high. Not abnormal in the substance abuse field, right? So we get them out of here. They were overdosing. When you went in there, they were overdosing every other day. And we were able to get them out on a scholarship somewhere, and now we're going to bring them home, and we are all about, part of recovery is making your amends and clearing your wreckage. That is my number 1 stickler. It's our 8th and 9th step, because you can't be free until that happens. But when you bring them home, they're in such a fragile state. And when we do bring them home, even if it's in New Jersey, they immediately come to our recovery center. That's the home base. It's the place where they come in their downtime. It's the place where they come in between work. So I think those are those are the big gaps. I hope I answered your question.
Yeah, kind of related to that. Chris, you talked about directly. You talked a bit about evidence-based programs, and you're describing, John, that it's 6 months. I imagine there's no magic number, but you're clearly saying a week or 28 days is not going to do it. Are you beginning at SAMHSA? Are you beginning to get enough data where you can clearly say what length of time is really required in most cases to help somebody turn the corner and begin to live a drug-free life and be in long-term recovery? Because the reason I ask that is I think we have to grapple with how long-term to pay for this. That's one of the things, as I said in my opening remarks, 2 things that we can do that are unique, I think, is we can provide funding on a massive scale and we can change policy on a federal scale, on a federal level. But we can't, nobody wants to spend money around here. And so to spend money, we need evidence-based models that can show us that if we spend for a certain amount of time, we can avoid this much in healthcare-related costs, this much in criminal justice-related costs. We can unleash this kind of productivity from people who re-engage with society in a positive manner. So can you unpack that a little more, the evidence-based work?
I mean, I think that's really where we are trying to help states with the discretionary dollars in particular, because it is it's the largest infusion of money specific to opioids that we've seen. And what we don't want is a sort of a Band-Aid approach where states are going to sort of buy services and people are going to get questionable treatment, and then maybe they stay in recovery for a few months, but then they're sort of back to using substances again, and we've wasted that money. I think the recovery part is a really critical part. I don't think we have data that says this is the point, because everybody's going to be different, and some people are going to have co-occurring substance use disorders or co-occurring mental disorders that are going to add complexity to their treatment. I do think we know that the use of medications is very effective, and I think what is important is that it's not just giving medications, it's the psychosocial support, it's the recovery support services. So in theory, individuals will need more acute treatment early on to get stabilized, and then as they're moving through the process, they should have less intense services. They're picking up recovery support services, which are certainly much cheaper because often peers and others are providing them. And sometimes they have no cost if you're doing 12-step meeting or self-help groups, those types of things. So I think we certainly can look at the economics to know that effective treatment is certainly cost effective. But we don't really have the cut points of this is where we should stop doing this or that. We do feel strongly that detox is not treatment. And that ends up wasting a lot of money. So in particular, if it's an inpatient detox and you simply have people physically withdrawn from medications and you send them on their way, you've essentially increased their risk for overdose. That's it. You've really done nothing else. So I do think that that's an area of policy where we need to discontinue the practice of supporting detox. And without having some sort of ongoing care, outpatient-based care, other treatment after that. I think the same could be said for 28-day programs. I mean, you're not going to address somebody's years of substance use in 28 days. I mean, that may be a start, and some people may need 28-day inpatient care if they have some sort of alcohol withdrawal that they need to go through, or long-term benzodiazepine withdrawal, or co-occurring serious mental illness that needs to be medically treated. But still, that's not the end. I mean, people would need ongoing care in the outpatient setting, recovery community supports, those types of things. So what we're trying to do with our discretionary dollars is to build the system. So hopefully people in New Jersey don't have to go to Texas. They can stay in New Jersey and get the care that they need in their communities. But it's not about building more beds, it's really building the spectrum so that the level of care that's needed can be provided in the community that's there, but the full spectrum of services are there. I have serious concerns that if we don't do that, we're going to have invested a lot of money in treatment that can't be sustained because we don't have the recovery support to match it.
I'm going to try to call on people in the order they arrived. I think down north across from New Jersey was next.
Thank you, Tom, and you actually started on time. You might be onto something.
We were very punctual.
Excellent. Well, first of all, thanks for what you do. And I wish you weren't the fastest growing caucus. And the reason I are is people are being touched. It's their friends, it's their family. Who being touched in a way that is horrible. The cost of doing nothing. I want to pick up on what Tom talked about. We do spend a lot of money, $717 billion on the NDAA. It's just a matter of making those resources available for where it'll do the most good. The cost is just so far beyond what the cost of treatment. I want to talk about that a little bit. What is recovery to you? What do you define as recovery? Because in your answer, what society believes is, I got called, prepare, but it's over. What is it? From that standpoint, what is recovery?
Well, I mean, there are various definitions that are used, but as a person, I'm 17 years in recovery, 17 in September. But for me, it's that you're showing up, you're a part of your life, you're able to function as a, I suppose, referencer or productive member.
You're clean?
Yeah, I'm using substance.
Not like you, but.
I mean, I think that there are, again, sort of varying definitions, but I think it is generally that you are not engaging in behaviors that are detrimental to your health, that you are able to show up and sort of participate in your life, that you are functional in your life. And I think that's how many people would recognize being in recovery.
So, as the disease progresses, and thank you for calling it what it is, the disease of addiction, what gets us here today is the fentanyl and heroin. It's just killing people so much quicker than alcohol. Do you see, from the medical standpoint, a difference between the main ingredient being alcohol versus an opiate versus cocaine? Or is it that disease of addiction the same throughout?
They all have very similar components in that they work in essentially releasing dopamine. That's sort of the reinforcing effect of substances. They have different effects and they work in different ways, but I mean fundamentally it's the pattern of behavior of reinforcing effects that people continue to have a drive to use substances that I think is the common element among those things. Some of them will kill you sooner than others, and that's actually why we have such big concerns around fentanyl, carfentanil, whereas alcohol may be a slower death from a substance perspective, but if you're driving, then alcohol-related car crashes are a very common thing, of course, cause of mortality.
So let me just follow up, and Tom brought up a great question. How do we afford to take care of it? Or how do we not afford to take care of it? Long-term recovery, what are the costs associated with that? Where do you see that going? I'd like to hear from each of the panel.
So, I mean, I think, again, the recovery support services can take a variety of different formats. I mean, it could be sort of one-on-one recovery coaching, it could be recovery groups, it could be having a physical location, sort of a recovery center where people can go and congregate. And
Do you include the 12 steps in that?
I mean, self-help programs, sure. They're part of recovery support services. They're a common element for many people in recovery.
Thank you, Congressman. I would be remiss, former Governor McGreevy said, if I see Congressman Norcross to make sure he says hello. The answers to those questions are very important. The definitions are very, very important as we go through this. We're kind of an odd county in Ocean. This recovery support services was welcomed on the face, but when it came time to execute, it wasn't on.
Not my backyard.
And also, to your definition of recovery, it's freedom. It's freedom, and it's a smile on your face to just be grateful for the day. That's the best definition that I like, and that's the magic that works with these kids when we're seeing them in the room. Governor Christie was floored when we had the success we had, because he didn't understand what we were doing in there. It's like we knew exactly where they were, and we were giving them hope, grabbed by the hand, and that's what the Recovery Support Services is. Big issue we have in New Jersey, to just be completely blunt, is I've learned over the last 4 or 5 years, I've had some phenomenal mentors, but the prevention field eats up all the ground. And a guy like me, who's a Marine, who just learning how to spell the word grant, let alone know how to write one and execute it, the money doesn't always filter down. On the other side of that, they picked the Marines, so I'm never going to quit, and I'm not going to leave one person behind. I've had the blessing of having mentors like former governors and congressmen to be able to have our backs, and guide us through this stuff. There's a big thing going on in New Jersey right now, where there's a prevention agency that has a workforce block, that's been controlling it for a long time, and they want to know why prevention people can't train the recovery coaches. To us, it's kind of comical, but when we get into the conversation, if you were supposed to prevent it, how are you going to put the fire out? But
That was the ghost record.
That was not, sorry. I don't think we need more, we do need more funding, but we don't in the same breath. We need to have it redispersed, and it needs to be a fair way so that it can land in these organizations, and to show effectiveness, outcomes and accountability. That was why I was so proud to work with the prosecutor's office, because they weren't going to take no for an answer, and they were going to bring accountability to the system. And when I heard that first question the first time from the prosecutor say, why did 389 people walk into a police station? That does not make sense. Why did that happen? And that's the question that we had to start asking ourselves. Thank you.
John Bassett not only came in next, but he's the only one left.
Wow. You want to go to the next person. Thank you for being here, and I thank my colleagues for your leadership here and participation in this. I don't think that there's an issue that is more pressing for any of us in the Congress. The district that I represent is a district that's a large rural district in upstate New York. It's larger than the state of Connecticut. My district, it stretches from the Vermont line to Pennsylvania. And the question that I have is, how do we at the national level try to figure out what is working and then get that information out there to the constituencies all throughout this vast land as to what works? And how do we best make sure that the money is getting to the places, because we are at Congress through the CARES Act and the Cures Act and subsequent funding. There's been a lot of money appropriated. How do we make sure that the money is filtering into the right places to fund effective community-based programs?
So I think those are all really good questions, and certainly questions that we are facing and working on at SAMHSA. I think, as I mentioned, we launched an evidence-based practices resource center in April to get to this key issue of how do you translate some of the science and NIH funds into practice, and how do people become aware of that? Because there's a lot of information that's coming out on opioids, and so it's hard to decipher what do I need to pay attention to, what is actually helpful for what I'm doing. And so we've tried to create a resource that really distills down the critical components that communities or clinicians would need in order to implement evidence-based practices. And we are continuing to develop resources as we learn new things that they can be applicable to the field. So, providing those things are important. We also at SAMHSA are taking a revised approach to training and technical assistance. So for many years, we've had in all of the HHS regions, addiction technology transfer centers, which are essentially places largely housed within academic universities that are in a region to help facilitate the adoption of addiction treatment and other resources. We are soon to be standing up prevention technology transfer centers to do the same on the prevention side. I think as was mentioned, there is a fair amount of money that goes out to prevention, and there's a lot of variation in what are the prevention interventions that are implemented. And we definitely know that many interventions are not evidence-based or are not implemented to fidelity. So it might have worked in a study, but when a community tries to do it, they may not do it in the right way, or it may not be the right thing for their community. So we think that the prevention technology transfer centers can be extremely helpful in helping people on the ground implement evidence-based practices. So we're doing those things. We, as I mentioned earlier, for the STR dollars, are created a specific technical assistance program, which is again to work with the states to do an assessment of what are the needs. So as you're getting this money, so they just got $485 million, states will soon get another $1 billion that came through the omnibus. Planning, using data to say what's actually going on in my state. I think we all come to the table with perceptions of where we think a problem is, but when you actually look at the data, it might be quite different. So this TA is to really help the states think about where do we have adequate access to treatment, where do we not have adequate access to treatment, and then how do we use these dollars to fill those gaps. So we're trying to hit it on multiple fronts, from the national level through state-specific, regional level, to assist in the adoption of those evidence-based practices.
And what is, can you give us a sense of what the cooperation level of the various states is on being amenable to using the techniques and programming that is working?
I mean, certainly there is variation. I think states have been receptive to additional technical assistance and training, in particular if the goal is to tailor to their needs so that they are a partner in the effort versus we're just sort of spitting information to them of do this, do that.
Right.
But looking at it as a partnership, I mean, we work very closely with the single state agencies, the substance use agencies in the states, which are essentially the grantees for the larger opioid funding. So we work very closely with them. We meet with them, their organizations, fairly regularly to understand, what are the challenges that you're experiencing? How can we work through those things? We've tried to be flexible in the larger funding announcements so that states can meet the needs that they identify. But we are also trying to provide some guardrails to say, here's what is evidence-based. Here is what is effective. We have an expectation through use of our dollars that you will be pursuing those things.
Because when I have to say, when I read the individual 50 state summaries of how the state plan, now this obviously was just a synopsis, and maybe it was 2 long paragraphs.
Mm-hmm.
Much of it was just filled with jargon that really didn't tell you what they were doing with the money.
Right, and that is, I think part of that is the time frame, because if you actually go back to the states now, they have fairly short window to write a synopsis, submit a plan, but part of what they were also required to do was an assessment that came later. I think you see a lot of revision of what states are intending to do based on that assessment. It just wasn't able to be done in time for the actual first funding announcement. And I think in the second year, we've allowed additional flexibility. So in the first year, it was at least 80% spent on treatment and recovery, up to 20% on prevention. We've taken away, actually Congress directed us to do that so that there is more flexibility. So that if states have made really good progress on the treatment side and they feel like they want to invest in prevention, they have the flexibility to do that.
Well, I certainly want to maintain that flexibility. At the same time, we have to try to ensure that there's accountability, because the tendency of bureaucracies, especially when you're throwing a lot of money out to deal with a legitimate problem, is not necessarily to make sure that everything is being spent efficiently and wisely. It's to usually satiate the different bureaucratic demands that may exist.
And we are certainly capturing data on how how many patients are receiving services, what do the outcomes look like, and we think that will be an important feedback loop to the states. And then we're partnering with some states to evaluate what look to be particularly strong innovations, in particular service delivery innovations. So ED-initiated buprenorphine, safe stations, other centers of excellence model, hub and spoke models, so that we hope that it can be translated and scaled up in other states as well. So we're trying to narrow the gap between research and practice.
Thank you. Brian, did you not before you have something you want to add?
I just wanted to add to Congressman Kuster that we struggled with that. We struggled with that same question since we've initiated the program. What is success? Is it working? Is it not working? How do we do that? This SAMHSA grant for us is going to be critical because we're taking people, or we're taking resources, local resources, and trying to figure this out on our own, trying to crunch the data. But some of the problems we have is evidence-based outcome data is tough to get when you have a highly mobile population. They're poor historians of medical history. What works for one doesn't work for another. And then we get into when does recovery really happen and what is recovery? And it's such an individual thing. But we struggled with that. We struggled with it on the local level, and we as the fire department take no city funds for this program. The private ambulance company takes no city funds. It's only the service provider that has taken a small grant from the city to help with the transportation costs. So I'm with you, and we're doing it. We have to come up with those answers, and it's just so tough. Because sometimes a client would be in it, they're going to a program. Well, they're good in the program, they get out of the program, they go dark, fall off the earth, so to speak, and they can't get in touch with them. So that's another huge component of what we're trying to do locally through peer counseling and trying to get more boots on the ground, so to speak, to go out into the community and go to where they are instead of them coming to where the recovery is.
Just to follow up on this funding, because it's interesting to me. If you leave this area and go to defense spending, another area where we spend enormous amounts of money, part of the culture of defense spending is that the private industry is welcomed and relied upon, and enormous amounts of defense spending are actually spent with defense contractors, publicly held companies, for-profit companies. In this space, your question about spending money on prevention made me wonder, and tell me if I'm barking up the wrong tree here. Most prevention programs I've seen, I would put in the not-for-profit category or the governmental, the public square sector. It's schools, it's community-based organizations, and it's easier to give money in grants to organizations like that because nobody's scratching their heads saying, is somebody making money at this? When you get into the treatment and recovery side, it strikes me that, and I'm a lifelong businessman, so I look at things through that lens, that organizations that build scale and that build themselves as a for-profit organization might actually have an edge at providing these services. And yet, when you're using taxpayer dollars, that creates potentially a conflict. I'm asking, have you seen that? Is that part of the dynamic here? That this is new enough and that it's harder for people to feel that it's okay to spend taxpayer dollars on not-for-profit and for-profit entities?
That's the number one conflict every day, it appears. We've developed this program, as you know, with our local prosecutors. I never took any dime from them for a reason, as far as drug forfeiture funds or prosecutor use. He used it with local, I guess you would call them IOP and mental health agencies to fund them. What we wanted to prove was on the private side, you you get that client that's not just dropped off after the silo's done. The other piece with the state agency sides is, like I was just saying before, they work in that 14 to 24 days, and they may do a phenomenal job. But then after that 14 to 24 days, that individual's dropped off, if they stay in that program. Then they're expected to go to the next program, like the good fire chief was just saying. On our side, on the private side, we have an individual that gets them right there, and they're with them through the entire process. So that when that 14th day comes and they're not having a good day in that facility, and there might be bed bugs in the place, guess what? They can leave and we can tell them it's okay, but that doesn't end up in a fentanyl overdose. That means we're going to come back to the recovery center and figure it out together and keep them refocused on their goals. You know, that's only been accomplished by private pay and scholarship. When we get into the dollars, like we were just saying with the prevention agencies, the proper lane for the indigent individual should be from some of these grants that are coming down the pike. But the grants are gobbled up so quickly before, for example, I believe it was one of the $12 million grants that came out in the Cures Act. And I wasn't looking for grants, but you know, we started to look at this, and from several different law enforcement agencies, I received an email. I believe it was right around my birthday, October 20th, that this grant from the state level that was received from the feds was $12 million, and it was exactly what we do every day. And we would be able to do this all day long. The mandatory bidders conference was that Friday. Right? So I'm all over the place. You know, this is on a Monday. I got to learn how to spell the word grant, what it means and how it goes, and then I got to report to a bidders conference, which it just so happened that all those prevention agencies were at that bidders conference. You know, and it just so happened that that grant landed in that bidders conference. And then when they received the grant, they put up a brand new beautiful building. And Lifeline and the prosecutor's office and all those entities that are doing this on no funding are the ones still answering the calls in the ERs and still standing by their side in the jails in the moments of crisis. So that's where, and we just keep doing the work because we know the right thing happens. But once that funding comes around and lands in the right place, you're going to see more of these individuals. I mean, we serviced 894 in 1 year. Just in our little small compartment, and now we're going into Monmouth County. So that's a significant number. 25% is a significant number. Ocean was the #1 ground zero 2-3 years ago, and now we're not. We're further down. So I think that's really the takeaway from this: is how do we do it? Because you are upsetting an apple cart, and you're affecting administrative, salaries. People that have been doing this for 40 years. That's really where the touch point is.
Do you see, Director, from where you sit, a preference for government-based or not-for-profit, or are you sort of agnostic on?
I mean, our perspective is that we certainly want our dollars to go towards evidence-based practices, and in our funding announcements to the state, who would then subcontract or procure services, their expectations of what should be done and what types of services should be provided. I think there is a lot of wariness of people who have financial intentions versus actually, recovery and good outcome intentions getting into the business because there's a lot of money to be made. I mean, we see certainly increased advertising for certain treatment facilities on TV that often don't provide evidence-based care, but are very expensive and are very nice. So I think there's concern around that. There's concern around sober housing, which some of our dollars can be used for at the discretion of the state agency, but not to where it's an environment that is not safe for the individual, where you see some places in certain states sort of coerced to go into staying in a sober house if you're going to participate in treatment in some facility. So I think that there's a general concern to make sure that the dollars, again, are going towards evidence-based practices. But by the nature of providing medications, some of the states are contracting with individual office-based physicians to provide buprenorphine or naltrexone. So by their very nature, they're in it for a profit in this sense.
No, I'm ready to close, but I really appreciate you coming in. I just wanted to add, and we'll work on this going forward. looking for long-term solutions. And I think one of the biggest things for me, there's so many aha moments that we've had over the last, 3, 4, 5 years. But one of them is educating ourselves and our colleagues and our communities about long-term recovery. Because you really, it's changing somewhat just as this acknowledgement of disease of substance use disorder is definitely, we've enlightened a lot of our colleagues and a lot of our communities on that. But the concept that people, it's a 28-day one and done, you should be good to go. And you talk to families all the time, and they're like, he was in recovery, how did this happen? And there does seem to be a high recidivism relapse rate. So just briefly, and we can get into it in another event, Anthem, who's the big player for health insurance in our state, finally has a program that is a year long, and it is home-based intensive treatment, which is new. I had heard about inpatient, I'd heard about outpatient, and it's incredibly effective. And it's expensive. It costs $38,000 per person. But when you compare it to the expense of, we have hospitals in New Hampshire doing full-blown open heart surgery because heroin addicts get an infection that goes to their heart. At the same time, their ER downstairs is doing the Narcan and shipping people right out to the parking lot. And the hospital CEO is saying to me, well, the open heart surgery is reimbursed. The social worker, the recovery coach in the hospital, in the ER is not, And now we're learning and we're doing better. But I think there's something to this, figuring out the supports for, yes, getting through the detox, getting to the treatment and the stability, and if it's assisted treatment, if it's 12-step, it's some combination, and then recognizing long-term recovery. And I'll just say, we don't tell a diabetes patient, we're not going to treat you, you just ate cake. We say that's a really hard disease. How can we help you and your family? Because you really ought not to eat cake for the rest of your life. And let's figure out a way to support that. And I think that's, what Brian's and what you're doing is that warm handout, that moment of clarity, a place to go, plug the gap. You're plugging the gaps with the recovery coaches, and we're doing a lot more with that now. But just recognizing that long-term recovery, I think, is really critical. So thank you all for everything you're doing.
If I could add one thing that I'm finding more and more and more is we kind of talk about the person with the problem. Well, I'm starting to, when I talk to the parents and I talk to the people who are bringing people in, I'm starting to realize this is 3, 6, 10, 12 people behind them who this one person is affecting. And he's blowing up the family. He's not showing up to work, so his boss is losing productivity. He's costing the community money because now the family is on welfare and he doesn't have the job or she doesn't have the job. And this is one of the things that we're also trying to do, is get more service for the family members, because I'll ask people, are you getting any help yourself? No, that's 99% of the time. And there's a cost to that too. What is that doing to our society in terms of lost productivity in families?
Absolutely.
I have studies back in my office that suggest that for every dollar that we spend in helping people get off of drugs and stay off, that we save between $6 and $7 in healthcare costs, around $5 in criminal justice costs. We just think of the cost of housing somebody in prison. And then I met a month or two ago, about 2 months ago, I guess now, with Jay Powell, is the incoming chairman of the New York, of the Fed, not the New York Fed, but the Fed, the Federal Reserve. Odd discussion to have with the Fed chair, but it was about the 9 million people who are home every day, mostly men, who are home every day and taking opioids. Not necessarily addicts, but
Pain medication.
but in some cases pain medication, but working age adults, mostly men, who are home, 9 million, and the loss of productivity and the fact, so there's, you know, I appreciate what all of you do just in terms of alleviating the human misery that comes with this, but the most expensive thing we can do is underfund this and not get the resources to the right place. That's the most expensive thing. And John's right, we need accountability, but still the most expensive thing we can do is not get resources where they're needed. And that's what we're trying to do. So thank you for helping us, thanks for making us a little smarter today about what we can do. And unless there are other...
Thank you.
Thanks for making the trip.
Thank you.